20 now, so let's keep going. Maybe the propofol is helping. Yeah, do whatever you want to do. As long as it's good for the patient, I'm happy. All right, so we're doing L45. Everybody's in agreement. Left approach, that's where we are, right? What kind of marking pen are we using on the board over there? It's horrible. It looks like a dying cactus. We need to throw that away. There's no need for something like that. Why don't we have like a nice black colored pen or?
I keep putting one in here and it walks away. I don't know what happens.
Yeah, those marking pens are in high demand.
They really are.
Somebody's probably selling it on eBay.
Probably.
No, no Sharpies. We don't want to do permanent surgery. We don't want to permanently be operating on the same patient. All right, so this is a good time for the audience to ask me questions because we're just waiting to get the blood pressure down a little more before we get started. Sean?
There are no current questions.
Huh?
There are no current questions.
No current questions? What are you talking about? We've got a fire sale on questions right now. All right. That's good. Anything what? Anything new with the corals? How's he doing? Is he doing good? Nothing new with the corals yet. They're growing slowly. Too slow. That's the problem with corals is they die quick, but to get them to grow, they grow slowly. So slowly. Ready? Awesome. Yeah, I mean if only we could reverse that and have them die slowly and grow quickly, it would be nice. But corals they can take thousands of years to grow. That's odd. He's responding to my incision. Let's give him a little more local.
Any more pre-sub?
Just lay still. Everything's okay. Yeah. I don't think we need more, right?
No?
I mean, we don't need more than what I have.
Okay, that's perfect.
Yeah. He's very pain sensitive, that's for sure. Wow. Okay. Very good. Everything's going well. We're making our incision for the surgery. The incision is standard 7 millimeters. We make the same incision like this on every one of these lumbar. Now for the neck we only do 4 millimeters, but for the back it's 7. The reason it's 7 is that the dilator is 7. I'm sorry, the tubular retractor is 7. The dilator is about 6. Shot? Very nice. And remember, this patient has very nice discs, but he has a tear in the back left side of this 4-5, the annular tear, and that's really the main thing we're going in to fix. You can see the tip of the dilator is almost at the tear, really low in the foramen. Shot. That was interesting. I could feel it just go right through the tear. Shot. Yeah. This is going to be the most stimulating part of the surgery. This part right here where we're going into the disc through the tear. Shot. And he's not really responding very much. All right, I can't really do this with the guide wire in, so I'm going to take it out. Shot? Okay, that's good. Now he doesn't have a big herniation that needs to come out. He just has a tear that needs to be basically debrided. Yeah, shot. Ah. Okay, shot. He valsalvaed and actually pushed my dilator right on out. So when people valsalva shot, their intradiscal pressure goes up.
You want to push a little bit more?
Let go. Let go. Shot. Shot. Yeah, I need to put it in more. Shot. Everything okay? Huh?
That's current shot.
I didn't hear you. You doing all right? Shot. Let's get him a little bit deeper. Good. Pretty funny, huh? I need him a little bit deeper, otherwise he's just fighting me here. Shot. Everything's going good. Shot. How's he doing? Shot. Shot. That should be good. Take. Shot. Fluoro out. Good. Yep. Like I said, most of his disc is fine. We need to get to the periphery where the annular tear is. That's painful.
Scalp on, please.
Hold this here. Uh-huh. Let me just take a look. All right, we're switching to our endoscopic view. Stay there. Can you give me the laser?
You want the laser?
Yeah.
Can I release that one or no?
No, you cannot. Go ahead. All right, so we're inside the disc herniation, and this already looks abnormal. A lot of scarring. Sometimes we can be fooled by patients that have something called internal disc disruption, where on MRI their disc looks pretty normal, but then you get inside of it, you know it's the cause of their pain, and you see this kind of stuff here, where there's a lot of scar tissue from an injury that really doesn't make the herniation come out towards the nerve root, but it is definitely abnormal inside the disc. And that's kind of what we're seeing here. The old terminology is internal disc disruption. I didn't make that up. It's something, hold this please.
Yes, sir.
Something that chiropractors know about. And it's basically take an egg, a raw egg, and shake it up. What do you think that does to the inside of the egg? It's pretty bad. Or take a brain in a car accident, closed head injury, and shake it up. Person can die from the injury, standby wipe. But you won't see anything externally on the outside. The disc is the same way. And that's exactly what we're dealing with here. I'm sure of it. I can see it. This patient has a disc that's been damaged internally, and there's very little outside evidence of it, but on the inside you can see all the scar tissue that's not normal. It's not normally found inside the disc, and it indicates an injury to the disc. And this blue stuff stains degenerated nuclear material, which shouldn't be blue, it should be white. But the fact that it's staining blue tells me that it's already been injured and it's already degenerating. And what causes that degeneration is the breakdown of the nuclear material by chronic inflammation. And I can see this stuff here is all scar tissue from chronic inflammation. It's not normal, and it's calcified. It has a golden color to it. Very interesting. I kind of suspected this would be the case for this patient, given the fact their MRI looks so good preoperatively. And like I said, there are very few doctors in the world who understand this condition and understand that it causes pain, internal disc disruption. And it doesn't cause pain necessarily because of the part that's inside the disc. It causes pain because there's a tear in the annulus, and all of this pressure from all the swelling within the disc, from inflammation, because inflammation, as you all know, causes swelling, right? When you have an inflamed skin follicle in your face, it's a zit. You know, you have an inflamed follicle, it hurts. It's swollen, tender, and it hurts very badly to touch it. This disc is exactly the same way. It's swollen on the inside, stand by, and it's very painful to touch. Of course, don't let go. Nobody's touching it, except for me right now. But in this patient's day-to-day life, there's no touching the disc, but there's pressure, right? And the pressure from standing, walking, doing all normal activities, that puts pressure on this very sensitive disc. It's under a tremendous amount of pressure. All right, so the blue stuff is the degenerated disc inside. And I'm telling you, I can feel the pressure of the disc. It's under tremendous pressure. You can see it rolling and turning. All right, so we just want to try to get as much of the degenerated stuff as we can. Why am I getting wet, Luis?
Crystal. Can you check this bag, the water, please? Is too wet the floor? What's going on? Huh?
My foot's getting wet and water is coming down, so I don't know where it's coming down from. Usually Luis puts a Ray Tech around my wrist, which he's not done today.
You feel it there? You feel the water?
That's typically the reason why. He didn't do it today.
Yeah, I see that, but
Why am I seeing bubbles? Huh? All right, move. All right. There's the tear. Yeah, not a huge one, but enough. Plus, combined with the swelling of the disc from the inflammation, from the internal disc disruption. So, tear with swelling, that's the problem. It's like having one of those really small zits that aren't huge or ugly, but they hurt like hell. That's just inflammation, folks. Pressure and nerve fibers. The bad combination. You can see all the blue disc, right? That's degenerating disc. It means it's been injured and it's under the effects of inflammation. Doesn't mean it all has to come out. Only the interposed stuff does.
We have a question.
Yep.
One of our viewers notes, since there is no blood flow inside of the disc, with this disc that is internally compressed, how is there still inflammation?
Oh, it's a great question. I love it. So the viewer says, and we don't know who the viewer is, but I'm sure their name is somewhere over there. I don't know who they are, but thank you for asking the question. Great question. So because the disc has no blood flow, how is there inflammation? And how is it being compressed? So the first statement is not accurate. Discs do have blood flow. The center of the disc does not have a blood flow normally. The nuclear material in the middle does not normally have a blood flow. That is true. The inner half of the annulus fibrosus does not normally have blood flow. That is true. The outer half does. The outer half has blood vessels. So how could blood supply go from the outer to the inner? The answer is easy. An injury, an annular tear. It allows the ingrowth of blood supply to the center of the disc if it wanted to. Yeah, that's right. So inflammation goes where it wants to over time. You give it enough time, what happens is you have these what are called
Whoa!
Oh my god.
All right.
Pressure bag for me. Okay, I'm switching bags for you.
No, actually it's not very weird. It's kind of expected when you overinflate a pressure bag. So, well, something is gonna give, right? Basically, look at that right there, billowing out. You guys can see that coming out. When you have inflammation, inflammation is mediated by invisible little markers called inflammatory. Look at that explosion. So if you were wondering, is that thing under pressure? Well, there you go. Inflammation is mediated by cytokines, which are small proteins circulating, small molecules circulating, released by damaged endothelium. And those cytokines include endothelial-derived growth factors and interleukins, and basically little molecules that cause the ingrowth of blood vessels and nerves. Okay? They cause the ingrowth of blood vessels and nerves into an area of inflammation, into an area of injury. So if the disc is injured, look at that thing. That's incredible. Non-believers, there it is. Can you see this, Sean?
Yes, we can.
Look at the size of that herniation. It's all blue. It's stained. It's degenerated. Here you go, Luis. My present to you. And this patient is going to be very happy that it's gone. Trust me. Again, the way you get blood supply to the middle of the disc that normally doesn't have blood supply is through chronic inflammation. It's through growth factors. It's through molecules, signaling molecules that are normally found in the human body that promote the ingrowth of blood vessels, and those blood vessels cause more inflammation. They're there to support the inflammatory process. Okay? It would be like saying, all right, we're fighting in the jungle, right? We're in Vietnam, and there's no roads that go into the jungle. It's just jungle paths. And the United States drops its Army Corps of Engineers at the periphery or the edge of the jungle, and they start building roads into the jungle. Well, you could say, well, the jungle doesn't have any roads. Well, yeah, they didn't normally have any roads, but once you drop the Army Corps of Engineers off, the Army Corps is going to go in there and start building roads, you understand? To facilitate transportation of equipment and personnel to where the action is, to where the problem is, the pathology. Anyway, so you're correct in that a normal disc does not have a blood supply to the center of the disc. However, under pathological conditions, such as an injury to the disc, traumatic injury to the disc that causes internal disc disruption, now you have damage to normal tissues, and those normal tissues call for and promote the ingrowth of blood supply, which then gives you more inflammation. So yeah, this is a very swollen nucleus under tremendous pressure, very angry, and it's putting pressure on his annular tear, which was on the periphery, which we're going to see more of in a minute. And that's why this patient has so much pain in their back, even though the MRI doesn't look bad at all. There are very few surgeons in the world that would discover the source of this patient's pain. Most of them would blow this patient off, saying, there's nothing wrong with you. You're imagining it. Can't tell you how many times I've fixed patients that have had small disc herniations with back pain or neck pain, and they've been told by other doctors there's nothing wrong with them. More times than I could ever count, to be honest with you. Literally thousands of times. It's because the other doctors don't know how to fix this problem. And it's unfortunate. That's why we do this broadcast, is so people are aware, you know? That people are aware that there is other ways to fix back pain and neck pain other than what their doctors have available for them. And this endoscopic surgery you're seeing right now is one of those ways, which your doctor won't have available to you unless you're my patient. All right, just about done here deep inside, and we're going to next move to the periphery and finish up debriding the annular tear. I don't think the annular tear is a very big one. I think it's small based on what I've seen so far. I think the biggest problem was all this swelling of the disc, edema. And the edema has been putting pressure on the very pain-sensitive annular tear. So let's go take a look. Yeah. See how soft this is? It kind of just melts away from the laser. That's a good sign. It means it's relatively fresh and very wet. So this is, I think, relatively new type of injury that I'm dealing with right here. The original injury could have been a long time ago, but what I'm dealing with right now is fresh. Probably, if I had to age it, could be just a few months old. At least this part. Yeah. Amazing. This is one of the mysteries of chronic back pain, folks. It's like the mysteries of the deep in the ocean, you know, when they started putting submarines down a mile down and finding that there was life down there, really interesting life and interesting creatures and biological processes going on. This is like exploring the depths of back pain with a scope that goes to where very few people have ever been, because it's a new technology, sticking a scope into somebody's herniated disc, you know? And then look what we see. We see things that we didn't expect to see. Things that haven't really been described very well in the past, right? So 200 years ago, seamen used to describe monsters in the ocean when they were out in the deep sea. Oh, you know, serpents as long as your boat. Well, it turns out that those things do exist. They're giant oar eels, right? And for a long time, we thought that they were making it up, that it was fake, that they were probably delusional out on those boats. More than just scurvy, but other things going on. And then we find out that there are giant sea serpents. But they're harmless. But, of course, when you're on a ship and you're out in the middle of the ocean and you have no idea what's harmless or not. And so, obviously, that they were an object of fear. But now we know more about them because we've been able to study them better. Oh yeah, there's a Valsalva right there. You can see the pressure with coughing. Isn't that amazing? All right, I think we're almost done here. Thank you, Luis. This is looking pretty good. I think we're just about done. This is just the end of the tear right here. Honestly, yeah. I'm pretty happy. Less than 5 minutes for me. Less than 2 minutes. Less than 2 minutes. We need Patel?
Yeah.
Great. You're doing great. We're almost done. Just lay still. This is debridement of the annular tear, for those of you wondering. Same thing when you get into a shoulder, like if you're dealing with a shoulder, a rotator cuff injury, you can get in there and debride it like this. And you see the tendons and the ligaments just kind of rolling like that, you know? Because most of it's healthy. It's just part of it you have to clean up that's been chronically inflamed, trying to heal, but it can't heal, so you got to help it by debriding it. I feel pretty good. He's valsalving, and we're not getting any more material coming out, so I feel good. Feel good. Right there, let go. Yep.
Right, that's on, please.
Maybe, let me see here.
4x4, third speed.
Yeah.
Pencil
So we're close to the nerve root. His tear was right below the nerve root. I'll show it to you in a second here. You're doing great. Can you hear me? Yeah, he's awake, right? Oh, he's just kind of in and out of it. All right. You have a question, Sean?
Yes, we do.
Let me see.
We have a viewer wondering, after you remove this present tissue, what will stop it from forming scar tissue again in the future?
Yeah, great question. So what will stop it from forming scar tissue? We want it to form scar tissue. Scar tissue is collagen. And we want this disc to heal with scar tissue, with collagen. That's what the annulus fibrosis is. It's all collagen. It's all scar tissue to begin with. Just very organized scar tissue, and it's something you were born with developmentally. So yeah, we want this to heal. What's been keeping it from healing is the pressure, pushing on it. Imagine if you had a cut on your arm, and if you kept pushing on it every day, all day, just pushing, mashing, and mashing, and mashing, it'll never heal. Would it? So basically that's what, there's a nerve right there on the left at 10 o'clock, 9, 10 o'clock. And yeah, I think we're done. I think we're done here. Yeah, I feel good about it. We're done. So we want scar tissue to form to close the hole in the disc, in the annulus. What we don't want is we don't want chronic inflammation. So this patient's had chronic inflammation going on for a long time. And that chronic inflammation is what's causing the back pain and his symptoms going on the left side, down the leg. So it's the inflammation we don't want, it's the healing we do want. And the wound heals with scar tissue. So, all right, very good. Any more questions for me?
We do have another one.
All right, let me come to the conference room and I'll answer it for you.
Okay.
Our blood loss was 2 cc's, no complications. Good work, everybody.
Thank you. I'm so
Nice
sorry
job
that's bad.
popping a balloon for my birthday.
No, I haven't.
Thank you for joining us for the post-op Q&A. Please continue to post your questions in the chat. We have Dr. Duke in the room with us. He's ready to answer your questions live. Our first one comes from a viewer on Periscope who asks, what kind of sedative do you use, and is the patient awake? Likely in response to hearing Dr. Duke talk to the patient while they were under anesthesia.
Okay, good question. I love the audience because the audience always gets these really good questions, and I have answers. That's the good news. I have answers. So sit back, relax, and let's talk through this. The anesthetic that we use for this type of surgery, specifically the lumbar or lower back Duke laser disc repair, is an anesthetic called propofol. Now, propofol, you may have all heard about. Michael Jackson overdosed on propofol at home, injecting it in himself. So here's the deal, okay? And this is not just propofol, but this is all sedatives, all sedatives. There's a balance when you give a patient a sedative, whether it's an animal, a human, it doesn't matter. If you give too much sedative, it stops the patient from breathing. If you give too little sedative, the patient is awake. So anesthesiologists walk a fine line administering sedatives to patients during surgery, and that fine line is between the patient being too awake or the patient being too asleep. Now, by being too asleep, what we're talking about is those sedatives can shut the brainstem down. The brainstem is at the bottom of the brain. The brainstem is the area of your brain. It's one of the oldest, if not the oldest area of the brain. And it's the part of the brain that controls your breathing center. It's your breathing center, basically. And if you shut the breathing center down, you literally stop breathing. And we can't make you breathe if you don't have a tube down your lung. And we call that tube down in your lung endotracheal anesthesia. So the patients that are having the lumbar Duke laser disc repair and literally millions of surgeries a year, you know, they don't have a tube down their throat unless they really, really need it. So with this type of surgery, the Duke laser disc repair on the lower back, patients don't need to be completely, totally, under, where we have to put a tube down their throat and breathe for them on a machine called a ventilator, okay? When you see surgery done that the patient has a tube down their throat, that is general anesthesia, and those people are completely out and their brains are not breathing. And if we didn't have the tube down their throat and have them on a machine pushing air into their lungs, they would be dead. So we don't want these patients that I'm doing surgery on dead. We have to have the right amount of sedation to where the patient is still breathing and not apneic. Apneic means not breathing, so they're not apneic. They're breathing on their own. They have some oxygen going in a nasal cannula, but we don't also want them awake. So here's the deal. The anesthesiologist is always walking this line between too much sedation, too little sedation, and every single patient's different. So it's not like you can say, all right, give me 5. Like, when you go to the restaurant, right, to have dinner, they give you a burger or a steak, and they're all the same size, right? The burger is the same size for you as it is for the next patron, and that's because the portion's the same size. In other words, there's a standard portion when it comes to eating that human beings need with a certain amount of kilocalories, usually say 1,200 for a burger, and everybody gets a 1,200 kilocalorie burger. When it comes to anesthesia and sedation, it doesn't work that way. You have some people that are like Tyrannosaurus rexes. They need an entire cow. And there are some people that are like little mice, and they just need a grain or two of sedation. And everybody's body's different. And that's why it takes a specially trained professional to administer anesthesia, because there is so much variation in terms of how human beings respond to that sedation. So it's not a one-size-fits-all. That makes it difficult. So the anesthesiologist has to look at the patient while the patient's asleep and the surgeon is poking around in there, and the anesthesiologist has to go, all right, you're poking around a lot. The patient's a little light, I better give them a little more sedation so they don't wake up. Or the surgeon could surprise the anesthesiologist and touch on something that's really painful and suddenly wake the patient up when they were sleeping and comfortable before. So it's a constant, monitoring and adjusting the dosing of sedative during the entire surgery. So this type of surgery, believe it or not, the anesthesia for this kind of surgery is actually harder to do with the patient not intubated than it is with the patient intubated. Because when the patient's intubated, it's easy. They can open a book and they can just start reading. They can get on their phone and get on Facebook or whatever those, websites are, and they can have some fun and kind of get distracted. But when it comes to this type of anesthesia, this type of surgery, the anesthesiologist has to be on their toes 100% of the time paying attention. So why was I talking to the patient? You heard me talking to the patient not because the patient was awake, but you heard me talking to the patient just in case the patient was awake. Okay? So it's kind of like you hear a noise in the house late at night while you're sleeping. You get up, you think, well, I don't know if I heard something or not. But you say, I'm going to go get my gun and go downstairs, right? You have no idea if there's somebody down there or not. But you're going to say that anyway because it doesn't cost you anything to say it, and just maybe you'll scare them out of the house if they are there. So I'm talking to the patient saying, everything's okay, because I don't know where the patient is with respect to their sedation. Are they deep enough? They're just moving because it's a reflexive movement. Because we have reflex movements. You can be totally snowed and I could pinch your finger and you'll move. It doesn't mean you're awake and you're feeling it. It just means your body like subconsciously felt that pain and it pulled away. That's a reflex movement. It does not go to conscious levels necessarily. It's reflexive. It's at the level of the spinal cord or the brainstem. So what I'm getting at is the job of the anesthesiologist with respect to sedation for this type of surgery is extremely difficult. It's a constant teeter-tottering between too much sedation, too little sedation, or just the right sedation. And the anesthesiologist does their very best to monitor the patient to keep them comfortable, but they don't know if the patient's necessarily maybe a little bit light or if they're a little too deep. If they're a little too deep, they have certain things they can see, like their breathing slows down and they start to obstruct, and they have to push their jaw back and get their tongue out of the way and put an oral airway in. I mean, there's a lot of little things that they look at to see if the patient's too deep in sedation, and there are things they look at to see if they're too light. Most notably, their blood pressure starts going up, their heart rate starts going up, their breathing rate goes up, and they start to move on the table, move around, like purposefully. So that tells you the patient's too light. So, like I said, it's just a complex dance between too much sedation, too little sedation, and you want to just get it just right where the patient's out of it, not aware of what's going on, but still safe with respect to their airway and their breathing, and they're not obstructing, okay? And then what sedative do we use? I told you propofol. There's lots of different ones, but propofol is the very best in the world. So it's the safest. Patients wake up from propofol sedation, they feel like $1 million. How do I know? Because I've had propofol sedation for my colonoscopies. Isn't that wonderful? And I always go back to work the same day afterwards because I feel so good and I have so much work to do. Anyway, long story short, propofol, best in the world for this type of work. A lot of surgery centers, hospitals, they go cheap. Propofol is expensive. We pay a lot more for propofol than any other sedative. Propofol costs us more, but it's the best for the patient. It literally, patients love the recovery after propofol. Now, we could give them the old cheap stuff, like fentanyl and Versed, super cheap, doesn't cost the surgery center much. We save money there, but the patients feel groggy, sleepy all day. They feel like disgusting. And frankly, if it was me, I wouldn't want to feel disgusting like that. So I always put myself in my patient situations so that I can think, what would I do for myself? And I'm kind of a minimalist to begin with, but even I know the best thing is to provide the very best for the patient with respect to sedatives and other equipment. So we spare no expense. We do the very best. Propofol is the way to go, and every anesthesiologist in the world will tell you that. That was our only question. You all type too slow. You all got to get the questions typed up quicker, and then I can answer them for you. Well, that was a pretty quick surgery. I think Dr. Patel's in there doing a rhizotomy, where he's zapping the pain nerves to the facet joints, and then this patient will be ready to go home. Our patient currently that's having surgery, we just finished up, is from Texas, and the patient before that was from Canada. So we have patients from all over the world that come to Duke Spine Institute for the endoscopic Duke laser disc repair. And I even had 2 weeks ago a lovely patient from Canada as well, who is here having surgery, and I'm wishing her a very speedy recovery. You all have a great day, and we'll talk to you again next week.